I think it's probably 9:14 and 30 seconds, so I'll get going. I don't need to be right on time. So I'm Roxy Albrecht. I'm the Vice President of Southwest Surgery this year, and want to welcome you to this morning's CME section on surgical practicum. So we have 5 talks this morning. 3 of those will be in person and 2 are going to be recorded. After each talk, we'll give some time. There should be 20 minutes in length, and then we'll have time for questions for the presenters, and I'm sure they'll stay around at the end if we have some questions at the end that people think about after they hear some of the other talks. So our first presenter is Krista Copps, a good friend of mine for probably about 30 years now. I think Krista and I have dated each other, known each other through the years, and date ourselves at the beginning of this organization. So Krista is Professor of Clinical Surgery at the University of San Francisco, Fresno, and is Director of the Surgical Critical Care at Community Regional Medical Center in Fresno. Krista has been active as a member of multiple professional organizations, including my ski buddy at Western Trauma, and she's been past president of the Northern California chapter of the American College of Surgeons, a member of the ACS Committee on Trauma, and most recently has been serves on the Trauma, Burns, and Surgical Critical Care Board of the American College of Surgery, and just recently was elected to the Council of the American Board of Surgery. Krista also has a master's in public health from London School of Hygiene and Tropical Medicine, and she's given numerous talks in Africa and Asia in her international educational endeavors. So Krista's going to talk to us today on non-operative management of appendicitis. Krista. Take it off.
I was just wondering about this whole mask thing. I don't know. I mean, I don't know. We'll take it off. Okay. And I promise not to breathe on you.
Yeah.
Great.
Jill comes in and scolds us.
Well, okay. We'll see what happens. We'll take our chances. So, good morning, members and guests. I am so very pleased to be presenting this talk in person and not just talking to the computer. That is one of the worst things. It really makes you think you're losing your marbles. I also have to say, it does seem a little bit odd that the first talk at a surgical meeting should be about non-operative management. Like, what heresy is this? But the other thing that occurred to me is, as I was preparing, I was reminded of 2 patients way back when, I think we were in the anesthetic and antibiotic era, the way Dr. Albrecht is describing it. But the very first patient I met as a 3rd-year medical student on my first surgical rotation was a 21-year-old young man who had a perforated cecal carcinoma. And I just remember just being so floored and appalled by that. The other patient I was thinking of was during my internship, my first appendectomy. Yeah, those were open in those days. Some of you know how to do those. And I remember standing there desperately wishing for a dotted line for where to cut. I don't know if anybody else has experienced that. So we might as well go ahead and get started because there's a lot to talk about. And I learned a lot putting this together. I've got nothing to disclose. That's Half Dome at Yosemite, which is it's a couple hours from where I live, although right now you probably couldn't see it for smoke. So anyway, what we're going to talk about today is examining the subject of appendicitis. Is it the same everywhere? Is all appendicitis created equal? What do we know about non-operative management? Is it effective? Is it safe? And if we're going to do antibiotics, what should we be doing? Interval appendectomy. And what about appendicitis in the time of COVID-19? Because right now you can't have a talk without mentioning COVID-19. So the incidence, most common surgical disease worldwide, lifetime risk is about 7 to 8%. We consider it a surgical disease. Mortality rates are actually quite low, certainly with unperforated appendicitis, and higher with patients who do have perforation. The postoperative complication rates in uncomplicated appendicitis range from 10 to 20%, depending on what you consider a complication, and certainly significantly higher in patients who have perforated appendicitis. What's interesting is that the incidence of appendicitis has been declining steadily over the last 70 years. I don't know if, somebody's out to get rid of our surgical targets or what. Currently, the rate in high-income countries is about 106 to 110 per 100,000 person years, which is the unit we use for comparison. But the presentation, severity of disease, workup, operative management are really variable depending on a country's economic status. We're looking at high-income countries compared to low and middle-income countries. And we see geographical distances. If you look at the differences, if you look at the lifetime risk, different in the United States and Europe compared to Africa. Perforation rates also vary depending on what study you look at. So how do we know what we're up to? And, I mentioned the incidence has been declining. Somebody sat down and pulled out 120 studies reporting on the incidence of appendicitis or appendectomy over as far back as they could go. And this is looking at pre-1970 data. So 50 years ago, and the incidence in North America or in the United States and much of Western Europe was greater than 150 per 100,000 patient years. If we go and look much more recently, up to 2014, you can see that the incidence in North America has declined greatly and also in Europe, but it's really still low in Africa. So what is going on? Why is this? And the answer is we really don't know. We also, as we're looking at appendicitis, we look at rates of acute appendicitis and we look at perforation rates because that's really the complication we're worried about. And it's important to consider how we're examining the data. We look at population-based studies, and most studies you look at, when they talk, they'll look at all the cases of acute appendicitis within that study or what they know about in that population, divided by cases of perforated appendicitis. Well, we don't know the actual incidence, and so these are guesstimates. But we have used these to link this to disparities in the rate of perforation, because we've said, hey, the rate of perforation must be people who are not getting care appropriately, because the belief about appendicitis has always been that it starts and inevitably progresses to perforation. And the question is, are all populations equally affected? But we tie this into insurance status, age, whether somebody has access to care, whether they're in a rural area, how well the hospital supplies. And these are just a few studies, but there's an association between markers of reduced access to healthcare and an increase in proportion of perforation. So that has been linked in that. However, I will say, and it's been considered to be a great subject because it's such a neatly defined diagnosis. It's, if we say peptic ulcer perforation, well, that can include a lot of things. And it's thought to be characterized by a consistent natural history. But the belief that this is random in onset and consistent progression has really been challenged. Not all appendicitis is created equal. And the thought is, do perforated and non-perforated appendicitis really represent two distinct processes? So Luckman looked back in '84 at age-adjusted incidence of appendicitis, used California hospital discharge data, got him a whole bunch of patients. And what he found was that there was a significant age-related variation in the incidence of non-perforated appendicitis. And we say, well, we know that. It's more common in a younger population. But the incidence of perforation really, an abscess did not really change. And we say, well, older people have a higher proportion of perforated appendicitis. That's always been one of those things that we know. But really, that higher proportion may be that there's a lower incidence in that population. More recently, study that came out of Washington, looking at all the hospital data, linking it to US Census Tract data. Their hypothesis was that the incidence of acute appendicitis would be higher in higher socioeconomic areas because those people have got access to care, they've got insurance, there may be medically more sophisticated. And what they found was that socioeconomic advantages were strongly associated with a lower incidence of acute appendicitis, but it didn't really make a difference for perforated appendicitis. So what's going on there? We don't know, but just to say there's a lot we still don't know. So if acute appendicitis is a surgical diagnosis, why are we talking about non-operative management? And somebody recently surveyed 304 general surgeons in 39 countries. Over half said that non-operative management was a viable management option. They said, yeah, that's something we could consider. But the vast majority don't use non-operative management. And about an equal amount, 78% said, if it was my appendix, take it out. Don't give me antibiotics, which was, I think, unsurprising considering the resurgence. So as we're looking at non-operative management, there have been a few studies. It's kind of started back in the 50s, reporting kind of little case series, reporting successful treatment, but it's really in the recent past that we've had a huge increase. 1977, there was a study from China that said, hey, they successfully treated 93% of their patients by traditional Chinese medicine alone. I don't have any more details about that study. But in 1995, there was a study where a randomized controlled trial with 20 patients in each arm, patients who had pain for less than 72 hours. Of the ones managed non-operatively, one had a perforation and about a third had recurrence within a year. Small series. If we really want to take it to an extreme, because I'm talking about antibiotic treatments, this was a study where randomized controlled trial, antibiotics, no treatment, either no antibiotics or no surgery. Yes, I don't know if our IRB would go for that, but this is what they did. Interestingly enough, 9 patients in each group had initial failure. 15 went on to have appendectomies. But what was really interesting is that after a median follow-up of 19 months, a year and a half or so, 20%, 21%, 23%, they basically had an equal percentage who required subsequent appendectomy. So not treating the patients was as good as giving them antibiotics, apparently, and apparently 80% or 75 to 80% did well. Interesting. I throw that out there. But let's look back at the data for antibiotic treatment. Probably one of the most quoted studies was one that came out of Finland. They enrolled as a randomized controlled trial, 530 patients, adult patients with CT-proven uncomplicated appendicitis. And they randomized them out. The surgical success group, they managed to get all but one appendix out. I'm not sure what happened with that one. The antibiotic group at 1 year had about a 25 to 30% failure rate, patients who went on to require appendectomy, and that was what they reported. And what makes this an interesting study is that it was a randomized controlled trial, but they went on to look back and study these patients at 5 years. You know, most studies you see, I know in trauma patients, if we get 40% at 3 months, we're pretty happy. They had almost all of their patients back at 5 years. And what's interesting is that you see the cumulative index of incidence of recurrent appendicitis, 27% at year 1, all the way up to about 40% at 5 years. The overall complication rate, however, was actually higher in the appendectomy group at about a quarter, and 6% in the antibiotic group. So greater number needed appendectomies, smaller number, but had lower complications. They did a 7-year follow-up study. They got 423 off. It was a kind of a quality of life study. Patients reported similar quality of life. There was no difference in patient satisfaction for the patients who'd been successfully treated. Unsurprisingly, the patients who later had to undergo appendectomy were less satisfied than the patients who did have successful treatment, although a third of them said, given the choice, they'd try antibiotics again. So data that we have there. A lot of studies have gone on, and meta-analysis of antibiotics versus appendectomy for non-perforated appendicitis, 5 studies, all randomized controlled. They had 434 had open appies, about a quarter had laparoscopic. Major complications in about 5% of the patients who had antibiotic treatments, about 8% in the appendectomy group. Recurrence rates were about 22%, and they felt that that was high quality evidence as that is rated. So about 22% 22 to 25% seems to be about the standard rate. And as you see in this table here, major complications, this overall was higher in the appendectomy group, and the rate of complications. What they did include were 32 perforations. And I think that was the lion's share of the major complications, frankly, although there were other significant ones, including a death. 5 more trials, another meta-analysis. And again, reduction in risk. Some of the things that favored were reduced risk of complications, decreased pain meds, but overall treatment treatment success was more likely with appendicitis, or with appendectomy, sorry. The failure rate for antibiotics was about 40% in this meta-analysis. Now, Dr. Poda looked at 20 studies with 3,600 patients, pretty evenly matched for antibiotics and appendectomy. The complication-free success rate was 82%, and treatment efficacy based on 1-year follow-up was about 93%. What they did find was that the rates of complicated appendicitis with peritonitis identified at the time of surgical operation and surgical complications were equivalent. And I'm sorry, I should clarify, is that the complication-free treatment success rate here was for appendectomy, and I should clarify, I apologize. But they said, look, the complication rates were about equivalent. And so Dr. Poda considered this some more, and this is quoted from the study. It said this could be a feasible treatment option for image-proven uncomplicated appendicitis, although the complication-free rates are higher for surgical treatment. It doesn't statistically, if you try antibiotic management, it does not appear to increase the perforation rate. It may fail, and another 20% might need more hospitalizations, but it seems to be safe to do this. So he then carried this forward, and a prospective multi-center trial looking at a propensity score matched analysis, appendectomy versus conservative treatment. Dr. Poda, and this was published this year. So they said the complication-free treatment success rate was about 65% for antibiotics, 82% in the API group, and said, you know what, LAP-API is still the gold standard, but conservative treatment with antibiotics is a safe option in most cases. Remember that these are patients with uncomplicated acute appendicitis. About 2/3 are going to be symptom-free at a year without risk of adverse effects if symptoms recur. So, you know, most of these studies have been in Europe. Vast majority, in fact, some centers report that they treat 40 to 50% of their appendicitis patients with antibiotics. So what about the United States? Now, this is a cleverly named study, and we might have had some people who participated, the multi-center study of treatment of appendicitis in America. This was a prospective observational study, about 3,600 patients. What they find, this is an observational study, so there was no intervention. Most patients got CT imaging, had LAP-API, and stayed for about a day. Of the patients who were selected for initial non-operative management, about 20% needed appendectomy. The other interesting conclusion was that any in-hospital delay to appendectomy was not a risk factor for complicated appendicitis, that the perforation had likely happened before the patient ever arrived. And I think for the people in this audience and those who are listening at home, as we say, we all have had patients who present relatively quickly, but have had perforated appendicitis. And even when you ask them, they've only had symptoms for 6 hours, you interrogate them and they still say, nope, I had no pain before that, but have had perforations early. Other patients who have had symptoms for days and their appendicitis isn't that exciting. So we wonder about that. The large study that came out called the CODA study, and this is one of the larger studies, pragmatic, non-blinded. It's hard to blind for a surgical study. 25 US centers, 1,500 adults, half and half, randomized to antibiotics and appendectomy. By about 90 days, 3 months, about 1/3 had undergone appendectomy, 40% of the ones with appendicoliths, 25% of the ones without. The rate of serious adverse effects was essentially similar for both groups. And the finding by the statistical analysis was that antibiotics were non-inferior to appendectomy on the basis of results of standard measures. So this came out in the New England Journal last year. So, you know, there's data there and we're looking at it. What is uncomplicated appendicitis? I'll submit that this CT scan is not uncomplicated appendicitis. When is non-operative management likely to be successful? Interestingly enough, several studies have found that patients who have longer durations of symptoms, more than 24 hours prior to admission, are more likely to have successful non-operative management in the absence of evidence of abscess perforation. Other independent predictors: lower fever, not as sick, image confirmed uncomplicated appendicitis, smaller diameter of the appendix. Big thing, take home message, presence of an appendicolith seems to be an independent predictive factor for both perforation and failure of non-operative management. If you see that appendicolith, non-operative management is unlikely to work. And if you don't have abscess or phlegmon on CT. Do we need imaging? You know, I've bemoaned the fact sometimes it's like, can't somebody show up with right lower quadrant pain and not get a CT scan? I mean, our CT scan is, you know, running constantly. Well, in an examination of 705 patients by clinical criteria, they sorted them by complicated, uncomplicated, compared the groups by age, gender, duration of symptoms, fever. They even got C-reactive proteins on them to CT findings. And unfortunately, neither the clinical or lab findings were reliable enough to estimate the severity of acute appendicitis. And so CT scan seems to be the thing that helps us sort out the differential of complicated versus uncomplicated, much as it pains me to say that. What about the risk of neoplasm? Because that's certainly a concern that we have if we're going to try non-operative management. You know, we certainly don't want to miss a malignancy. We know overall that appendiceal tumors are present in about 1% of all patients, and the rate varies. If you've got a patient who presents with an appendiceal inflammatory mass, the rate's about 10 to 20%, much lower in uncomplicated appendicitis if there's no mass present. The CODA study, that large study based at the University of Washington, reported about 9 patients with neoplasm, about 0.6%. So right in that 1% kind of estimate. There is no great data, but extrapolating from the World Society of Emergency Surgery acute appendicitis guidelines, there's a clear association of neoplasm with age. The older you get, the more likely it is to happen, which is not so different from colorectal cancer as a whole. Interval appendectomy is not felt to be necessary for pediatric and young patients. Call young what you want. Overall, and again, this is extrapolation, in patients greater than 40 years, consider colonoscopy and full dose CT scanning for follow-up and follow-up with appendectomy. Antibiotics, got the whole thing here. And basically amoxicillin clavulanate with metronidazole, ceftriaxone with metronidazole, cefotaxime with metronidazole. You get the theme. Sort of general GI kinds of treatments. Given it, these are intravenous antibiotics. And so the study was to say, can we give PO antibiotics? This study was just published a few months ago, trying to look at oral treatments versus IV treatments. They did 2 days of IV followed by 5 days of PO, or I'm sorry, 7 days of oral compared with IV for 2 days and 5 days. Treatment success was about 2/3 all around, but it failed to demonstrate non-inferiority. So the double negative did not prove what it set out to do. So right now, I think it's going to be IV antibiotics, and I'm getting ready to wrap up. Last thing, yeah, I know, I've got the red light going. I see that. I'm finishing. For those who've given up hope. But in the time of SARS-CoV-2, COVID-19, the use of non-operative management has increased significantly worldwide. You remember last summer or last spring when we were just trying to figure out what we were doing trying to keep people safe, trying to understand what was going on from a disease process. I'll use the United Kingdom as an example. They made a contingency care plan. They've got the National Health Service, so they can just shift the whole UK to that. And they decided to go with non-operative management as much as they could due to concerns of spreading the infection. So they did an antibiotic first appendicitis pathway, interim analysis for 500 patients. They said, okay, they had 271 that they initially treated conservatively. Only about 10% went on to get an operation. Those were done, the ones that were done laparoscopically. They said, you know, our hospital stay was shortened. And at 30 days, the complications were significantly higher in the operative group. And it might have been that those patients were sicker. This was not a very sophisticated analysis. There were no deaths in any group. 14 studies then, looking at all of that. And the big thing is that use of non-operative management during the pandemic, like looking at countries, seeing what they were doing overall, was significantly more likely than before COVID-19. Mean failure rate, mean complication rate, there's significantly lower odds for complications. So in the time of COVID, non-operative management has proven to be a viable option. So finally, I'm going to finish. My point being is that not all appendicitis is created equal. Non-operative management can be considered, realizing you may well have a failure rate of 20 to 30%, but selecting the proper patient is crucial. Patients over 40 do need follow-up, and coronavirus has certainly changed our lives. Thank you very much. I don't get to run away.
No, you don't get it right away. So we ask that if you have some questions, if you go to the mics, this is being recorded. So we have that then on the recording. So Chris, I do have one question, and that's where it perplexes me, is the length of therapy for the antibiotics. And, you know, if you keep them in the hospital for 4 days to 7 days, you know, are there studies out there that have any markers similar to C-reactive protein or things like that, white count, fever, that you can look at and decrease the length of stay and switch them over to oral?
Yeah, the one study I quoted that looked at entirely PO versus 2 days of IV and then switching over to PO. I think there's reasonable evidence to start out people on IV, see how well they're doing, and then switch over to PO antibiotics as much as you can. But yeah, this is new ground for us. So yeah, absolutely.
Yeah, but just recently I had a military guy just 2 weeks ago came in and adamantly did not want surgery, had early appendicitis, no fecal lith, and kind of used whatever we could to decide whether to switch him over to PO antibiotics, because as we all know, our hospitals are fuller than full at this point in time, over 100% capacity. So I haven't heard that he's failed yet.
Well, I've always wondered about the patients we had who you knew they had appendicitis, but they declined surgical treatment and they didn't come back.
Dr. Mangren.
And a very nice presentation. This is almost scary for me, you know, to even have the discussion, but I guess we have to have it, you know, because it's one of those operations that actually fix somebody. You know, I remember somebody once said, you know, if you're going to have, you know, obesity surgery, there's the gastric bypass, there's the sleeve, there's the switch, there's a this. It means none of them work. Okay. But appendicitis, you get an appendectomy and it works. And you go home and you're done and everything is just done. So I rose to say that because this is a surgical meeting and we do surgery and people get better. And my only question was, we're going through this whole antibiotic. What's the right antibiotic? So I was happy to see that slide near the end because our hospital and with our antibiotic stewardship, blah, 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 you know, they want for colons, everybody to get Ancef and Flagyl. I don't know, I guess that's the new thing now. And you kind of touched on it a little bit, but if we're going to tell somebody that you have appendicitis and I'm not going to operate on you, and mainly because we have COVID in the hospital, even though I could just send you to PACU and send you home and operate on you. But if I'm going to not operate on somebody, what do I do? Like Dr. Albright said, you know, how long do I put them on antibiotics? How would I ever make that decision when I could just take you to the operating room and operate on you? But I know we have to have this discussion. So
Yeah.
thank you very much.
And I know, and those are excellent points, and I agree with you. And you know, it's that satisfying thing. You take them to the operating room, you've addressed the problem, they're all better, and they go home. You know, it is that difficulty, but I think it has to be something you do, as Dr. Albrecht was discussing, was in discussion with the patient, because they have to understand that there is a possibility that this may not, you know, the antibiotics may not be curative for them, but there may be some patients where you say, you know, the patient who's got terrible COPD and you're concerned if they are a terrible ejection fraction, a cardiac thing, and you're worried about the risk of general anesthesia perhaps, or the patient with COVID. And I think we're all, you know, the patient who comes in and, oh, by the way, they've got COVID, and giving them a general anesthetic or an inhalational anesthetic may actually exacerbate that, you know, but it's got to be a discussion. It's not as straightforward as just taking the operating room. And I think the treatment courses, you start with IV and switch to PO. And those antibiotic guidelines were out of the World Surgical WSES, World Society of Emergency Surgery Guidelines 2020. So, you know, if you want to look those up. Thank you.
Yeah.
Hi,
Name, please.
Alexis Crowley from Denver. I was just curious if you knew of any studies or groups in the US that were actually interested in what the costs would be for patients who get a hospital stay with IV antibiotics and then they fail and have a readmission. Is that cost appropriate for our hospitals or even them?
That's another good question. And as you can see, I ran out of time, but there are economic analyses, mostly out of Europe. And because an operation is an expensive thing. And so for most of them, and the hospital stays were actually reasonably short. And again, we're talking about uncomplicated appendicitis. It actually, the antibiotic management was cheaper and as a generalization. So great question though.
Thank you.
Thank you.
May I
Right
escape?
on time. Yes, you may escape. So our next talk is going to be virtual. It's previously recorded, but our speaker is on Zoom, so we will have a question and answer session after the presentation. And this is by Bartley Pickren, who is an associate professor at the University of Utah. He specializes in colorectal surgery and has a clinical interest in laparoscopic and robotic surgery. He completed his colorectal fellowship at the University of Southern California and the Norris Cancer Center, and joined the University of Utah Healthcare following 10 years of practice at the Texas Medical Center in Houston. So Bartley's going to present diverticulitis, when to operate in the non-emergent setting. So another non-operative talk here.
I hope everyone is having a great time in Hawaii. I unfortunately wasn't able to make the trip this year, but I do look forward to seeing everyone in person, hopefully next year. So I'm Bartley Pickren. I'm a colon and rectal surgeon from the University of Utah in Salt Lake City. And today we're going to talk about diverticulitis, when to operate in the elective setting. So what we'll discuss in this talk is the management of persistent recurrent diverticulitis. We will go over complications of diverticulitis, including stricture, fistula, and abscess. We will then wrap up with some thoughts on the decision-making for surgery. And lastly, reminders regarding surgical technique. As this talk is about the management of diverticulitis in the elective setting, we will not be talking about emergent conditions such as peritonitis or free perforation. That way I won't have to talk about laparoscopic washout or lavage. And we definitely will not be talking about the role of popcorn, nuts, and seeds in diverticulitis. So the pathophysiology of diverticulitis comes from either perforation or translocation through a diverticulum into the pericolonic tissue. The severity of the disease depends on the degree of the body's ability to limit that contamination. Once the limited perforation occurs, then the disease may result in simple local inflammation. It may also worsen and turn into a phlegmon or abscess, and these abscesses can decompress into a fistula. So once this local inflammation occurs in an uncomplicated fashion and then is treated, then that local inflammation begins to resolve. In most patients, this occurrence is a one-time thing, and that's it. However, symptoms can recur following complete recovery. Up to 18% of patients treated as an outpatient are at risk for disease recurrence, and that number increases to almost 1/3 of inpatients who will develop a recurrence. However, the risk of ultimately needing surgery in this population is still only in the single digits. So the other possibility for patients with diverticulitis is that they never really recover from this episode. This may occur after the first episode or any other episode, and they develop persistent or chronic diverticulitis. We can then classify persistent diverticulitis into two categories. There's inflammatory, where there are objective markers of ongoing inflammation, and then there's non-inflammatory, where these markers of inflammation are absent, but the patient is still experiencing symptoms. This is an important distinction we'll discuss later when we talk about surgical decision-making. So looking at complicated diverticulitis, we generally refer to diverticulitis resulting in a stricture, fistula, or abscess. A stricture can occur from repeated inflammation. This inflammation results in replacement of the normal colonic wall with scar that then causes luminal narrowing. The other possibility is that adhesions from the surrounding inflammation cause the colon to kink on itself, resulting in an obstruction. Symptoms that go along with an obstruction are the ones you would expect, such as cramping abdominal pain and constipation. There's a special mention of a stricture that precludes endoscopic examination of the proximal colon. For this reason, we usually recommend resection to these patients due to either diagnostic uncertainty or the inability to offer appropriate colonic screening or other evaluation. So from a fistula standpoint, colavescal fistulas are the more common one. This is basically due to the fact that almost everyone has a bladder, while only half the population has a vagina. So typical presentation of colavescal fistulas is pneumaturia. They may be associated with frequent urinary tract infections. Then as the acute inflammatory event concludes with decompression of the colon and the bladder, the abdominal exam is usually benign by the time this process has run its course and the patient presents for evaluation. To evaluate these patients, the finding of air in the bladder on CT scan with a lack of recent instrumentation is diagnostic. Most contrast studies are unrewarding. Many of these patients may be initially referred to our urology colleagues. If cystoscopy is performed, there is usually a punctate erosion noted in the dome of the bladder. Surgical management of these patients includes sigmoid resection with bladder drainage. Bladder repair is indicated only if there's an obvious hole. Otherwise, Foley catheter drainage is significant. We usually obtain a cystogram on day 3 and then remove the Foley if it's negative. If we do have to perform a bladder repair, then we usually obtain this study on day 7. Patients with colovaginal fistula usually present with passage of stool or air per vagina. Their surgical history will almost always include a hysterectomy. Similar to colavescal fistulas, the clinical exam is usually benign. It's important in these patients to perform an examination of the distal rectum and the vagina to confirm a colovaginal fistula as opposed to a rectovaginal fistula. Usually with the colovaginal fistula, you will see a defect or granulation tissue with drainage at the apex of the vaginal cuff. It's rare to need a contrast study to confirm a fistula if you have an appropriate history and physical exam. However, in some cases, contrast studies may be helpful, and either contrast enema or a vaginogram may be appropriate depending on the capabilities of your radiology colleagues. CT scan is certainly reasonable in this evaluation to rule out the presence of an associated abscess. Treatment is similar to that of a bladder fistula. The affected colon is resected, and the vagina usually will heal on its own. Another complication of diverticulitis is the development of an abscess requiring percutaneous drainage. The presence of an abscess is a sign of significant disease. Patients who recover from an abscess have about a 50-50 chance of recurrent symptoms. About 60% of these patients will go on to require surgical resection. The two predictors for recurrent disease in an abscess are location in the pelvis and size greater than 4 centimeters. So according to the American Society of Colorectal Surgeons practice parameters, the presence of an abscess requiring percutaneous drainage should make you at least consider elective colectomy. So putting this all together, we'll go over the easy ones first. Stricture and fistula are indications for sigmoid resection in a patient who is an appropriate surgical candidate. So yes, we should be offering those patients surgery. For the patient with an abscess, we should probably be offering those patients resection as well. It's fairly common to see patients who have an abscess who feel fine when they see you 6 to 8 weeks after resolution of their disease and their drain is out. That then turns into a discussion. When a patient has no symptoms and have recovered well, it's hard to convince them that they need an operation to make them feel better. However, they do have to be counseled about the high risk of disease recurrence. So for these patients, I'll frequently tell them that I'm fine watching them if they have completely recovered, but if they develop another episode, it's time for resection. If patients continue to have ongoing symptoms following abscess drainage, then generally we should be recommending resection of these patients. So now for the challenging discussion. What about the patients with recurrent or persistent symptoms? So there's multiple factors we need to examine. For patients with recurrent diverticulitis, how often do these attacks occur and how severe are they? I'm going to be hard pressed to offer surgery to someone who has diverticulitis once every 2 to 3 years and lasts for 2 days at a time with minimal impact on their quality of life. So ultimately the questions are, what is the impact on their quality of life? What about their ability to work or care for their family? Lastly, we have to consider patient comorbidities, such as immunosuppressed patients should probably be operated on earlier rather than later due to the risk of worsening disease. So for patients with persistent disease, this discussion can be fairly challenging. For those with ongoing objective signs of inflammation, surgery is usually beneficial. For those with only subjective signs and symptoms, outcomes are more unpredictable. I'm sure we have all operated on someone for diverticulitis only to find a relatively normal looking colon or only mild inflammatory changes. Or even worse, we operate on them and their symptoms don't really improve that much. For these patients, I usually have the conversation with them that we know they've had diverticulitis in the past. Maybe their symptoms will improve after surgery, maybe not. Maybe these symptoms are more IBS related. The challenge in this case is to really set clear expectations with both ongoing medical management and with surgery, including the 10 to 20% risk of surgical complications or ongoing symptoms afterwards. However, from the flip side, some of these patients who choose to proceed with surgery have impressively bad disease. In the end, there's some of these cases you simply don't know. So when we talk about goals of surgery with these patients, in some cases, they had such a bad episode, they absolutely do not want to go through this again. So their goal of surgery is to prevent future episodes. For other patients, ongoing symptoms have worn them down, so their goal of surgery is an improvement in quality of life free from abdominal pain and other GI symptoms. So the one point we need to be careful about discussing is surgery as a prevention for the development of future complications. We used to be concerned about diverticulitis getting worse. So we would warn patients that they should be concerned that the more episodes they have, that the more likely their colon is going to weaken, the more likely they have a free perforation, and then they need an emergent colectomy with a colostomy. Many studies have demonstrated that this really isn't true. The first episode of diverticulitis tends to be the worst, and it's also the highest likelihood of having an abscess or needing a colostomy. The other two factors we have to be careful with are patient age and the number of episodes. While diverticulitis is becoming more common in the younger population, there is no research that indicates that the disease is likely to be worse or more likely to recur. So age itself should not play a factor into our decision to operate or not operate. Similarly, the number of episodes that a patient has had, if taken in a vacuum, should not tremendously influence that decision either. The recommendation used to be surgery after 2 episodes. However, as in the example earlier, if a patient has 6 mild episodes over a 5-year period that don't significantly impact the quality of life, then really there's no reason to operate on that person. There have been some cost benefit studies that have arrived at the number 4 for the number of episodes in which surgery is more cost effective than medical management. But I feel these other factors that we have discussed are more important when making the decision for surgery. So regarding surgical technique, just a quick reminder for tips for these operations. So number one, these are elective operations. Do what you can to allow the acute inflammation to resolve prior to proceeding with surgery. Now, that's not always possible for patients with frequent recurrences or those with persistent disease, but if you have the opportunity to allow the acute inflammation to completely subside, then that's really what we should be aiming for. Number two is that all of the inflamed colon should be removed. The proximal margin of resection is soft, healthy colon. The distal margin is going to be at least at the upper rectum. So there are cases where the disease is in the proximal sigmoid or distal descending colon, and you're removing what seems like a lot of normal sigmoid. That's okay. If the disease goes up the descending colon, then you'll have to remove that, and there's a decent chance of having to mobilize the splenic flexure in order to get the colon to reach the upper rectum for an anastomosis. The critical point here is not to leave residual sigmoid colon below your anastomosis in order to minimize the risk of disease recurrence. Next, just because you're removing the inflamed colon doesn't mean you have to remove all the diverticular disease proximal to the inflamed segment. Again, as long as you're not leaving diverticula distal to the anastomosis, then you could be in good shape. Some of these cases, especially the colovesical fistulas, colovaginal fistulas, I find to have significant inflammation and can be quite challenging. Use your ureteral stents if you need them. If they make you feel better, then by all means do it. And lastly, these elective cases should be done in a minimally invasive fashion. Whether you perform these operations laparoscopically or use the robot, that's your choice. You will occasionally need to convert these cases to open depending on the degree of inflammation and the ability to visualize critical structures. But if you can get the operation done in a minimally invasive fashion, then outcomes do tend to be better than those done open. So in conclusion, we should be offering elective resection to patients with complicated diverticulitis involving a fistula, stricture, and most of the times a pelvic abscess. Multiple factors should be considered when making a decision to offer surgery to a patient with diverticulitis. Patient age and the number of prior episodes should not be considered absolute indications for surgery. Recommendations for patients with recurrent or persistent disease can be challenging. These patients should be treated based on an individualized factor after informed discussion with a knowledgeable surgeon. So thanks again to the program committee for allowing me to present, and I do hope that everyone continues to enjoy a wonderful time in Hawaii. Thank you.
Thank you. I don't know if we're going to have Dr. Pickering up on the screen on a Zoom connection for any questions. Hey, thanks for coming out of the OR and attending.
Hey, yeah.
Southwestern Surgical.
Yeah, perfect timing, right between cases.
Yeah, we really wish you could be here with us, but
Oh, not as much as I do.
you have a calling there that's more pressing right now.
Yeah.
I don't see anybody at the microphone right now, but I do have a question. You know, this is a quandary between the acute care surgeons as myself and the colorectal people of, you know, you have a patient present to the emergency department and they've gotten a CT scan on them and they have evidence of diverticulitis and free air. And so I didn't see that patient as part of your operative intervention. And so who should that go to? Should that go to the colorectal surgeons or should it go to the acute care surgeons? And how would you manage that patient?
Well, I think obviously it depends on what time of the day it is. So no, I mean, that's one of the things we discuss a lot. I think it depends on the urgency of the situation. I mean, frequently, and it depends on your institution. I mean, I think that both specialties are equally capable of handling a perforated diverticulitis in an emergency. But a lot of times, at least at our institution, the acute care surgeons are basically they're there, they're ready, and they can intervene on that patient much sooner than we can either get out of the operating room or get out of clinic or do whatever else that we have to do. But if the stars line up, then I think either way is certainly appropriate.
Our kind of quandary is because we see our colorectal colleagues performing a one-stage procedure, whereas we are more likely to perform a two-stage or a colostomy in those types of situations. So studies that kind of show any differences or benefit of the patient in those situations.
Yeah, no, I think there's definite benefit to, if you can do a one-stage procedure, do it. But of course, in the acute setting, that's uncommon. There's a lot of intraoperative judgment depending on the health of the patient, the physiologic status, the condition of the colon, and on and on and on. But certainly, I think that given other options, there have been a good number of papers that show doing an anastomosis with a proximal loop ileostomy is far superior to doing a Hartmann's procedure in those equivocal cases where you're concerned about doing an anastomosis or not. Certainly patients who, you're going to bring them back for washout and open abdomen and things like that. I mean, that's eventually going to lead to a colostomy. I think there's very little doubt about that. But if you have the opportunity to do an anastomosis and then do a loop ileostomy, I think it makes recovery easier, certainly makes the takedown easier. And there have been studies showing benefit to that as compared to Hartmann's.
Great, thanks. Josh Mammon.
So Josh Mammon, University of Nebraska. I'm going to go, enjoy your talk, first of all. I'm going to go to the opposite extreme that Dr. Albrecht did and talk about the really mild cases that you had alluded to. The individual who has an episode every couple of years and it's a really mild episode. And maybe these questions go to their primary care doctor, but how would you counsel them, one, in terms of what sort of diagnostic tests they have if you're kind of sure that this mild episode that they have every couple of years is really diverticulitis? And secondly, in which circumstances would you advise to not give antibiotics at all and just do anti-inflammatories as some have proposed?
No, those are two good questions. I think, first of all, my phone is rapidly dying, so if I just go away, I apologize. But in regard to the first,
Getting out of this.
in regard to the first question, I think that's a concern, and we see that a lot where you see someone had one episode of diverticulitis, had a CAT scan 4 years ago, and then they have abdominal pain every few months, go back to their primary care. It's like, oh, you must have a flare up, so here's some antibiotics, and they get better. And you don't really know what's going on because they've only had that one initial diagnostic episode. So what I usually tell these folks is we talk about all the pluses and minuses of surgery. And I say, you know what, next time you have one of these flare-ups, give me a call. Let's get a CAT scan. Let's see what's going on. If there's inflammatory changes there, then I think you've got a good answer and a good justification for surgery. And if not, then, maybe you're looking into other avenues such as just, IBS or other functional bowel problems. But those tend to be pretty challenging. And then the second question was, about antibiotics or not. There's a lot of data out there that's getting more and more robust about non-antibiotic management of diverticulitis. But unfortunately, I don't think that as surgeons, we have the ability to move that needle because this is all, or most of it is run through primary care or the ER. I mean, you got to remember, there are so many patients out there with diverticulitis who we never see. But I think when you have these patients who have these recurrent episodes like this, if you can prove it's diverticulitis, then, maybe you do antibiotics, maybe you don't, depending on the degree of inflammation. But I certainly think that there is a role for starting with non-antibiotic management for these either persistent or frequently recurrent patients.
Well, thank you, Bartley. I want you to speed up because you're starting to cut into the time of the acute care surgeons at your institution probably. It's probably getting close to 4 o'clock, and that's our time.
All right, well,
So get going on your cases so we can get going, they can get going on theirs. So appreciate this. Thank you
All
very
right.
much. Great talk.
no, thanks. Good to see everybody. Take care.
Our next speaker is Shanu Kathori, and he's the Vice Chair of Medical Affairs at the Department of Surgery at Prism Health at Greenville, South Carolina, and Associate Professor at the University of South Carolina, Greenville. Shanu was in private practice or community practice at Gunderson Clinic for nearly 20 years, and that's where I know him the best from. He was trained there and then went back after his minimally invasive fellowship to Gunderson and was quite involved in the residency program and establishment of a minimally invasive and bariatric program at Gunderson Clinic, and was also the director of that program for 18 years or so. He's the past president of the Wisconsin Surgical Society and chapter of the American College of Surgeons. He's currently the second president-elect for the Fellowship Council for the American College of Surgeons. And he's a president of the American Society of Metabolic and Bariatric Surgery and president-elect of this august association, Southwest Surgical Congress. Shanu? Yeah, speaking on, forgot his title, New Options in Anti-Reflux Diagnosis and Treatment. That's not bariatric. Whatever.
All right. Thank you for that, Roxy. Yeah, so 24 years in the frozen tundra and moved to beautiful South Carolina. And actually, that's why I got involved in this society. I have to admit, full disclosure, my motives were not pure when I joined the society, because it's always in exotic locations when it's still terrible weather in Wisconsin. And so, but here I am, being a privilege to stand before you today. These are my other disclosures, none of which should be specifically related to this particular topic. I was involved in an original trial, didn't receive a dime for it on an anti-reflux procedure. My hospital made out just fine at the time. And if you guys really don't care about the GE junction, that's fine. You feel free to sign 100 notes right now. You have my permission. But otherwise, for those of you who are kind of passionate about this, I'm going to talk about why we should be doing more surgery, not less surgery, like we may have heard previously. So acid reflux is not an acid problem. It's patients with acid reflux don't make more acid than anybody else. It's a valve problem. It's a sphincter problem. And acid is designed to be in the stomach, does a lot of good things, starts digestion, kills bacteria, begins the absorption of a variety of things. And so making this an anti-acid problem is not really getting at the root cause. And I can't argue with our GI colleagues or primary care colleagues if the goal is I want my patient to feel better. But they're not really getting into the root cause that we as surgeons do. And we also know that this landmark Archives of Internal Medicine May 2010 article, which came out with the article showing about C. diff and weakened bones and low magnesium from chronic PPI use, showed the prevalence of what we know of Gerd in our country against the number of prescriptions prescribed in our country. And it is overprescribed by 69%. And if you and I did surgery unindicated 69% of the time, you know what that's called for us? Prison. Okay, so just like medicines have advantages and side effects, surgery has risks and benefits, and all of these must be balanced. But since those articles, just in the last few years, we've seen now some other articles showing the long-term use of chronic PPIs use. And most people don't know they're FDA approved actually for 12 weeks of use. That's still what they're FDA approved for. Now they're over the counter, people on them 20 years. And we're now realizing that's maybe not such a good thing. Recent articles in the last couple of years, increased risk of stroke, heart attack, dementia, renal failure. And it's getting into the lay press. And I'm actually seeing patients in my office that come in and say, hey, you know, my loved one has dementia. I don't want dementia. And I've been on this pill for 20 years. And correlation, causation, okay, but it's not, you're going to have a pill and you're going to get dementia, but it's just, there's something else going on out there and we need to at least take pause. Again, this is not an acid problem. It's a sphincter problem. And don't think that when you're on your pills, and I'm sure maybe even some of you in this room are on them, don't think you don't have acid reflux anymore. You still have the same number of acid reflux episodes in 24 hours, whether you're on the pill or whether or not. You've just altered the pH. You just don't feel it as much. And so that's where we think this problem is coming, because the number of reflux episodes doesn't really change. The pH of the refluxate does. And that's where I think we're getting into trouble, because when you get a pH in the 3 to 4 to 5 range in the lower esophagus, and you get the permeability changes of the cell there, the bile salts can get in, they can't get out, they can do bad things at the cellular level, and that increases your risk of Barrett's. And here we go, wondering why we're up 600% increase in adenocarcinoma of the esophagus in the last 20 years. This is a valve problem, and there's two components to the valve. You've got the crural pinch, and then you've got the intrinsic muscle. And so you need to address both of these if we're going to be thinking about treatments options. And this is a great slide that talks about the lower esophageal sphincter pressure in relation to the length of the valve. The best way I think about this is blowing up a balloon. When you start with a balloon, it's got a very long valve stem when it comes right out of the bag. It's easy to blow up, but as you continue to blow it up, the valve stem gets shorter and shorter. And guess what? The pressure on your lips to hold that closed is tighter and tighter. So the shorter the valve, the more pressure it takes to hold it closed. Longer valve stem doesn't take much pressure to keep it closed. That's reflux. When you start damaging that valve and shortening the valve, it's going to take more and more pressure to hold it closed, which the natural body doesn't have. It opens up and creates reflux. And so you're like, well, how can that happen? Well, because particularly like for those of us at the reception last night that overate, you can distend the stomach. And when you do that, pardon the analogy, but we just had a colorectal talk, but it's like doing an anorectal exam. When you spread the buttocks to get a good look, that's what you're doing. You're exposing the lower esophageal sphincter to a noxious environment intermittently that it's not used to seeing. Acid gets there, damages it, it closes off, does bad things, shortens and heals with scarring. And so here we are with a shortened valve that's now incompetent. Now you could argue, which is more important, the valve, the intrinsic muscle there, or the crural pinch of the diaphragm when you get to hiatal hernia? The answer is both. Elegant study by Brian Louie showed that intraoperatively, where half the operations, they closed the crural first and then measured the pressures, and then the other half, they did the wrap first of the Nissen and then measured the pressure. And believe it or not, each one contributed about 50% to the LES augmentation. And so you keep that in mind. Now, Rudolf Nissen was not laying in bed one night saying, oh my gosh, I think I can help patients by augmenting the lower esophageal sphincter by wrapping the top of the fundus with receptive relaxation. It'll relax in concert with the lower esophageal swallow, and this is the treatment. No, he stumbled on it by cutting out a GE junction tumor on a young gentleman with a perforated ulcer at the GE junction. Now, the Witzel tunnel had already been invented, and so he Witzeled the esophagus into the stomach and did it with a Witzel tunnel. By golly, the kid didn't have reflux when he woke up, and he thought he was onto something. So about 5 years later, he had the wherewithal to try and do that, which is now the Nissen fundoplication that we have to this day. But it took him a couple of years, and then there's a whole nother story about, which I love to talk about, the fact that he operated on Einstein and did his AAA and things of that nature. But I only have limited time to go into all the relationships between all of that. So interesting, he called this a simple operation for the control of reflux for those who are versed in German, which of course we now know is not. It's far more complex than we think. It isn't necessarily reproducible in everybody's hands. We all have our own little tips and tricks for doing it. Works about 90% of the time, 90% chance that you can be heartburn and regurgitation free and off your pills. That's about the best of any of the operations that we traditionally have, but it does have a defined failure rate. And those of us who do these know this. And so the question is there something we can do better than this? Well, we thought we'll add some mesh to that hiatus, and that'll help reinforce it. And we had a great paper at 1 year with nationally recognized thought leaders talking about that until the 5-year paper came out, and the recurrence rate was 50% with that particular mesh. We're like, well, okay, it was just that mesh. And then another multi-center study just recently came out with a different kind of mesh One, I'm not a fan of putting permanent stuff near the GE junction, but this one came out and same thing. The recurrence rate at 3 years was no difference between primary repair and mesh. So that's not particularly helping us as well. And hernias recur. Doesn't matter if they're at the umbilicus, the groin, or the diaphragm. We've never figured out how to keep them from recurring. We get creative with fancy repairs, but the natural history of that disease is it will come back. The full wrap, partial wrap debate, you know, how much reflux control do you want versus side effects? It's not that the Nissen fundoplication doesn't work, it works too good. It creates a supraphysiologic valve. It doubles the pressure of the lower esophageal sphincter to what it originally was, which is why many patients cannot belch or vomit afterwards, and then they trade off, they get the gas bloat syndrome. It's the trade-off for that supraphysiologic valve that we have created there. So comprehensive meta-analysis was done, and this is the way the jury landed, which is you're going to have better reflux control with a full wrap, and you're going to have less, but you're going to have more side effects. Or you can do a partial wrap and not have as good of reflux control, but you'll have less side effects. So then it's about managing expectations. Where does your patient want to live in that? What's the chief complaint? For me, if they're coming for reflux, then I want to give them the best shot at the reflux. So the question is, can we do better than this? Now in the world of social media, the rap gets a bad rap, pun intended. Patients go on there and talk about these terrible things that can happen with it. And so they'll come in saying, I don't want this, I want something else. And we saw the rise and fall of the fundoplication, you could argue, and what happened in 2000 that so caused the decline of the Nissen? Was it because I went into practice at that point and my outcomes weren't as good? No. Perhaps, maybe a little bit, but no, it was because of a landmark paper by Speckler, very flawed analysis saying that 2/3 of patients were back on their pills within 2 years of surgery, which is simply not true. I don't have time to break down that paper for you, but nevertheless, something that we can use in the armamentarium. Raise your hand if you do anti-reflux surgery, just curious. All right, so I'm speaking about 5 people right now, that's awesome. Any of you guys use FLIP? Any of you use FLIP in your practice? So what's one of the lessons I live? You're going to take a new job. You have to say, what's your wish list of all the things that you have to have? You're going to take a new job. So this was one that I made at my new job in South Carolina. I said, we got to get this technology. So this is functional lumen imaging probe, EndoFlip, where during the operation, you basically fill up a water balloon across the lower esophageal sphincter. You can replicate Brian Louis' study live with this. So, we know what it's like when you're looking at the GE junction, and it's like some people make that too tight and some people make that too loose. I mean, how do you know what's right? Here, you can tailor the operation. With this water balloon, we'll create a distensibility index. And so you can get a sense of, did I put one too many stitches in the crura, or is it time to cut one out because I over tightened it? And then you can add your wrap or whatever anti-reflux procedure, and you can see this number come down again. And so there's emerging literature on this technique. This was my very first one. So on the top picture, you can see the LES was incompetent. There's just basically nothing there. And then after I did the anti-reflux procedure and did the crural closure, you can see that nice pinch point on the lower bar there. And so you want to get that distensibility index down into a range of 2, 3, or whatever. Now you're in that sweet spot, perhaps, where we can put a little science behind that, which we're just eyeballing when we look at the screen. Good friend, Dr. Ujiki, has published on this extensively. And again, you can just see each time you add a component to the operation, you can see how you are impacting that distensibility index and augmenting that sphincter. So perhaps something to consider in your practice. So again, as we move forward with what else can we do, a lot of patients are fine on their pills. That's fine. We got the 1%ers that are doing the traditional Nissen fundoplication, but what about this group of patients that are dissatisfied? Escalating doses, costs, side effects of PPI therapy, but they don't want an traditional anti-reflux procedure. So you can, see what else is out there. Now, this is something that sadly I should have been using in my practice from the get-go, the Gerd Quality of Life Questionnaire, but I wasn't until I started enrolling patients in a trial. And it's originally 10 questions. It's been expanded to the one we have here, but where patients describe their own symptoms. And they said, oh, it's validated, it works good, and all this stuff. Well, actually, it's validated against the SF36. If you go back to the literature in the 90s, it's not validated to say you have reflux. In fact, we showed that here at Southwest about 2 years ago at our last in-person meeting. We looked at this data, and it's a scattergram. So patients cannot predict the severity of their reflux symptoms by talking to you in the office saying it's really bad. pain is subjective, just like any other post-surgical pain. And so you have to objectively work these patients up, because if we're going to move the needle on that esophageal cancer, what we need to do is normalize pH. And you got to always think of that when you're looking at papers in the literature, because otherwise they might talk about patients feeling better, which is great if they came in and they scored really high on it, and now they come back and they see and they scored really low. But did you move the needle on the pH and make that normalize the pH in the lower esophagus? You need really good studies to prove that. One of these is the magnetic sphincter augmentation, the LINX device. And so this is a device that was FDA approved in about 2013 now. So we're starting to get some 10-year data on it. I know some of you are old school are looking at this going, oh my gosh, Dr. Potts is shaking his head. This is just another angel chick. Actually it works fundamentally different than the angel chick, though it's more dynamic. It's meant to just sit there like a bracelet. And then the beauty of magnets, when we played with them as a kid, is when they're closer together, they're stronger. When they're farther apart, they're weaker. It's a brilliant concept for sphincter augmentation. So the studies in Europe were for fecal incontinence going on with this device, while we're in the US working on it also on the GE junction. But it works. It doesn't work any better than this in fundoplication. You're still getting that 90% of patients off your PPI therapy, but you're getting what you went out in as on the side effect profile. Less gas bloat, because 90% can belch and vomit through it. So it's more physiologic. It can't overcorrect the valve. It can't make the valve stronger than than it was before. So that's where it wins out over the traditional anti-reflux Nissen fundoplication. However, its downfall is the fact that it is a foreign body. Any foreign body we put in the body, we know it wants to wall it off with scar tissue. So here you have to swallow through that. And so the dysphagia is legit. It's real. And you got to, patients have to power through it and realize that that's part of the normal healing phase. Sometimes it's very rare, but it could erode over time, far less than the original lap band by a decimal point movement, but it can happen. And occasionally there is that psychological intolerance where you just have, patient can't tolerate, like, get it out of me. And so you have to take that out. But it doesn't burn any bridges. It leaves other options open for other things as well. Now, a recent study was also done where we looked at this for regurgitation, the volume regurgitators. No pill will help that when your valve is so incompetent, you just bend over and your mouth fills up. That's going to need surgery, some kind of intervention. A similar study was done that showed pH normalization as well, and it really helps with regurgitation as well. The mistake we made early on in the trial was a minimal dissection. This is one of my cases on the left side of the screen, and then now we realize you should tear it apart like a Nissen and then just put the bracelet on like on the right side of the screen, and that the results are even better now. What about the big hernias? The answer is yes, you can do the bigger ones as well. And doesn't for those of us who are doing it for a while, I'll do the total intrathoracic stomach, same thing, bring it all down, close everything up on the diaphragm, and then put the magnetic bracelet on there. And we have equally good symptoms, whether it's big hiatal hernia or smaller hiatal hernia. So don't let that reason not to proceed. And then here is the non-FDA approved, so I can't really comment on it, but stay tuned in the next few months. We should be seeing, is there a role for magnetic sphincter augmentation post-sleeve gastrectomy? Because we know in 8 to 10% that is a refluxogenic operation, and we are definitely looking for something to help those patients as well. So again, this is sort of a fair and balanced approach I take when I talk to the patients. I don't try to talk them into one or the other, but there's advantages and disadvantages, and then just matching the patient to their preferences as well. Obviously, what is the best operation we have? Better than the two I just mentioned is actually gastric bypass, and that's not even what it's designed for. It's designed for, obviously, for metabolic and weight loss surgery, but when you make that small pouch, you know, how much can you reflux? There is a so-called acid pocket. A lot of the GI literature talks about it. And so I was naive enough when I first started my practice to think, well, if I'm going to convert a failed Nissen to bypass, I'll give them a little bit bigger pouch because it's not for weight loss. And boy, was that a mistake. So you need, if anything, you got to make a smaller pouch on these patients to try and decrease the amount of acid pocket there. And because of the physiology of such is you won't be able to shut that off. You'll increase your marginal ulcer rate. And I like to publish on my complications so that people can learn from them. And basically the marginal ulcer rate when I did it for morbid obesity was 5%. It was 50% when I did it for reflux. So if anything, you got to make even a smaller pouch for patients for their reflux disease than even for weight loss surgery. Injectables come and gone, don't really have a role. Actually, some pretty adverse events with injection into the heart and perforations and stuff from this. So they've come and gone. Endostem, where they thought you could, juice the vagus, came and gone. Lack of funding there. No future right now for that. Different plication devices are out there. I'm only going to talk about the one called TIF, transoral incisionless fundoplication, because it's the one that's got the most literature. It's been updated, and their goal is to can you endoscopically replicate that which we do with a traditional anti-reflux procedure. And there's growing literature out there, but you can't think that this is not, just because it's a non-surgical intervention, doesn't have complications. There are some significant ones in terms of, the spleen and hemorrhage and perforation, mediastinal abscess, pneumothorax. I mean, a lot of things that we don't often see in our traditional laparoscopic approach, you can sometimes get with these endoscopic ones. There's large meta-analyses looking at this, all slightly favoring this device, as well as in something in the armamentarium. And you can see here, again, just in general, sort of how well they do. Radiofrequency energy, also known as STRETA, where you inject electrical impulses into the GE junction. This is something that has argued whether it works by just burning your nerve so you don't feel it, versus the company says it will actually causes muscular bulk there as well. And Chris, I'm unable to advance the slides after that, but that's okay. If you can, there you go. They claim that they're adding bulk back there. Next slide. Again, large hiatal hernias are contraindications to this technique. So again, you need that crural pinch and you need intrinsic sphincter augmentation. This thing can only do intrinsic sphincter augmentation. Next slide. Again, lots of studies now on this, but the thing, unlike traditional anti-reflux surgery, is it doesn't work overnight like anti-reflux surgery. Nissen, fundoplication, door, links, the patient wakes up heartburn free the next day. Very gratifying. This one, you got to wait 6 months to see if it works, because you got to see if that bulk takes place at there, and then you wean the patient off pills and see if it worked. Next slide. Again, the question is, in the future, does it have a role in the failed Nissen fundoplication, or even the bypass patient who gets the reflux, or particularly the sleeve patient? I think that's where it's going to find its niche as we move forward. So next slide. A colleague of mine did this and showed it just briefly, looking at patients who did have problems with reflux still, and they can see pre and post STRETA. You stick the sticks electrodes in there, you juice it for a minute, and then it cools with water in the water balloon so it doesn't burn the mucosa while you're doing that. And this is the technique that's done as well. Next slide. This is an intriguing one. Yeah, that's all right. You can advance. This anti-reflux mucosectomy. Next slide. Really interesting. Just like Nissen stumbled on this idea of his Nissen working, this was an advanced endoscopic surgeon in Japan who stumbled on that. He carved a GIST tumor off at the GE junction, endoscopic mucosal resection. When it healed with some serious scarring, but the patient's reflux went away. So he had to dilate him because he did a 360 cut. So now he just does a 270-degree apple core. And when he gets this to heal, it strengthens and augments the LES and is helping to prevent reflux. Really intriguing idea. Next slide. And how it works by that stricture formation, presumably, is the way it works. Next slide. Here again, you can see improvement in pH afterwards, which is, again, the end game. We want to move the needle on the disease. We want to see pH improvement. Next slide. And so something to think about. Next slide. This is another study here, equivalent with this, where you can plicate or cut and just try and augment the valve in a similar fashion. Here we can see, again, improvement in that quality of life questionnaire, but where's the pH data? The patient said they felt better, but did we move the needle on the pH to be determined? Another version of this is what's called anti-reflux mucotomy band, where you take the band that you'd put on a esophageal varix, and you would pinch that off, and then you would carve that tissue off. This is another way to, in essence, cause that controlled scarring to take place there, where then you can, we're seeing some improvements in anti-reflux, again, in that Gerd quality of life scoring system. But where's the pH data to be determined if these modalities will be ready for prime time in the future? And then finally, we know about laryngeal pharyngeal reflux, LPR, the acid coming all the way up, tickling the vocal cords, causing cough, wheezing, voice changes, all these things, challenging patient population. Study out of Milwaukee, believe it or not, remember the Selleck maneuver when you're going to sleep and you press a little bit there? They did a study where they actually saw the upper esophageal sphincter was augmented by doing this, believe it or not. And so what did they do? There's a commercially available device now available that the patient can wear at night. I've only offered it to one challenging patient after a couple operations on her. And so this is how it is. They can control their own disease. And if they call back and say it's not working, I say, just keep tightening it. Thank you very much. All right. Okay.
Thank you, Shanu. I forgot in your introduction to say one thing, that one is that you have an ability to make up words and like reflexogenic, but also you can move states within the continent and make Wisconsin part of Southwest.
Well,
So Shanu was
Yeah.
the instigator of getting Wisconsin into the official Southwest surgical.
well, it
I
is
believe.
a proud moment. And again, we've all been mobile now. And I think our president lives in Atlanta in the Southeast market, and I do too. But I am proud of the legacy that many of my former colleagues do. And I've kept track of about 10% of the attendance and the presentations have been from Wisconsin over the last years. But honestly, that the credit goes to Dr. Edney, because he was the one who pushed me hard. I ran into him at the college meeting on the streets of Chicago, and he says, "Can I interest you in adult beverage?" And we went into a bar, and he cast his vision of how we need to expand the footprint and bring Wisconsin in. And so he was really the one who pushed me to do that. And so again, it's really a testament to Jim.
To Dr. Edney, yes, we will miss him. And I will say that there is a program book out in the lobby to give a note to Debbie, his wife, of the unfortunate passing of Dr. Edney about a month ago. So we really miss him in Southwest Surgical. I do have a question, and I don't even get close to this area unless there's a gunshot wound through it. And then sometimes I'll call in our minimally invasive people and our thoracic people to make sure I don't goon something up there. But in putting the links in, and you said that you had to strip that area quite open, similar to doing a formal Nissen operation or thing. Is it the scarring or is it the links? You know, because you're showing that you have all this stuff you can do
Yep, no.
endoscopically and cause scarring. So are you doing the same thing laparoscopically? Or
That's a great question. I think it's different. I think for links, it's actually the magnetic augmentation that's giving it. There are if you look at the pig models where you just take inject a needle into a porcine stomach and just start filling it with fluid, eventually you're going to see the fluid go up into the esophagus. But they have the studies where you take the links and you just put it around it, and instantly the stomach can handle much more pressure, much like my balloon analogy, before it gives way. But the scar tissue around the links, because of being a foreign body, is where the dysphagia that comes from. And so we had a dilation rate was 20% early on in our experience, we know, and we've published that it's down to single digits now. We just did not realize how important the patient's diet. They have to eat a bite of something, your 3 meals a day, plus you have to eat something a bite of something every 1 to 2 hours while awake for the first 8 weeks to rehab your device. Much like you don't want your knee replacement freezing up your joint, you got to rehab it. You have to rehab your device by actually exercising it, by eating. And so we realized the power of that. Now the dilation rate to go in there and break that scar tissue is much less in a more contemporary series.
thanks, Jeff.
Jeffrey Chow, Oklahoma. Great presentation. Enjoyed looking at all the reflux treatments, the new and the old, and I think I might borrow that to tighten the device. The one thing I'd be curious to hear your thoughts. What do you do with these patients with hiatal hernias that have a BMI of 35, 40, and 45? So, great data for using magnetic sphincter, but whether you look at primary anti-reflux surgery, some of the newer therapies, but what do you do and what do you tell your patients related to BMI?
Yeah, that's a great question. It's a whole nother debate in and of itself, is what to do for that patient. There's what's the literature would support, and then there's real world in terms of what insurance is willing to cover and things of that nature. So can I pick on you, Dr. Grover, my former partner, since you ran me out of Gunderson? But anyway, no, is because it's all in your delivery. So I had a patient, Dr. Grover goes in there and says, "I can't do anti-reflux surgery on you. You got to lose weight." And she gets mad. She storms out of the office. She goes, "Give me a different doctor." And so then they have to send her to me. So then I go in there and I sit down, I draw the pictures. I draw the wrap, I draw the magnetic ring, and then I say, but if you want the Cadillac, I said, here's what I'm going to do. I'm going to cut your stomach off. Look at this. I'm going to make this little pouch. So the acid is part down here. It cannot get up there. It can't splash up there because it's physically divided. I said, but you have to eat. So then I'll just reconstruct your intestine. I'll bring this up and I'll sew it here. So now your food goes down like this. The acid stays away. And it's the best operation we have on the market for anti-reflux. And I say, and it looks very similar to gastric bypass for weight loss, but we're doing it for you for reflux. And they go, I want that one. So it's all in the delivery, but when I'm very similar, translation identical. So a little bit's in the delivery of that, but then you also have to have a patient willing to go down that and be compliant and realize what that life is like, you know, because you're trading, you know, the compliance of supplements and vitamins and internal hernia and risk and stuff like that as well. And then they may not want to, and then they may not have insurance covering for that. You can push it as gastric exclusion with diversion and say it's not really for weight loss. But that's a separate challenge as well. And if they say no to all of that, then I set a weight loss goal, 20 pounds, do something to help me out here because of the durability, because we know that we think that weight does affect that. And of course I'm here and can't be SAGES, but my loyalty is here, and a 2-year project meta-analysis of all that literature is being presented at SAGES right now. So stay tuned. Unfortunately, it shows an opportunity where, and hopefully with our multi-center trials group, we can add to that literature, because sadly, after 20 years of us doing this anti-reflux surgery and metabolic bariatric surgery, there's a serious gap in the literature for the question that you just answered, or asked, I should say. I didn't answer it well.
Thank you. Very nice. So our next talk will be another virtual talk or recorded, and Dr. Tamanaja is on the Zoom connection with us also. So Gail Tamanaja is a practicing trauma and acute care surgeon at Scripps Memorial Hospital in La Jolla, California for the past 16 years. Prior to that, she was here in Hawaii as a trauma medical director at the Queens Medical Center in Honolulu, and helped that program achieve its level 1 trauma verification. She's an active member of the ACS Committee of Trauma and the lead physician for the ACS TQIP Palliative Care and Trauma Imaging Best Practice Guidelines. She's currently the American College of Surgeons Board of Governors as the governor at large, representing the fellows of San Diego chapter. She's active in the American Association for the Surgery of Trauma, Pacific Coast Surgery, and a very active member here at Southwest Surgery in the previous program chair for Dr. Margulies' meeting. So Dr. Tamanaja will talk to us today about small bowel obstruction and the updates and the management. Gail, welcome.
Thank you, Dr. Albright, Dr. Mello, and the program committee for asking me to talk today. I'm sorry I'm not able to be there in Hawaii to enjoy the meeting in person, but I put my virtual Hawaii background in to pretend like I'm there. I was asked to give an update on small bowel obstructions, and I'll start with some basics and then review diagnostic imaging, and then cover water-soluble contrast studies and laparoscopy in small bowel obstruction. Causes of small bowel obstruction are either extrinsic, coming from outside of the small bowel, intrinsic in the wall of the small bowel, or inside the lumen of the bowel. The most common cause of small bowel obstruction in Western societies is adhesions. Signs and symptoms include nausea and vomiting, continuous crampy abdominal pain, abdominal distension, high-pitched or absent bowel sounds, and history of previous abdominal surgeries. Laboratory tests are noted here. Of note, LDH and CK increase in any ischemic state and are non-specific. Serum lactate, however, is sensitive but not specific for ischemia. Lactate rises only at a stage when widespread bowel infarction is already well established and is assigned to proceed to urgent surgery. Recent reports indicate that although there is no relative clinical or no reliable clinical or laboratory marker for intestinal ischemia, and intestinal fatty acid binding protein, which is released by necrotic enterocytes, may become a useful marker for the detection of bowel ischemia. Laboratory tests can simply indicate general disease severity and can be used to support or rule out an emergency surgical condition only in the context of other clinical findings. Additionally, serum tests are indicated in the evaluation of any patient with abdominal pain because they may indicate needed adjustment of electrolyte abnormalities and fluid resuscitation. Small bowel obstructions are often difficult to diagnose, as early small bowel obstruction may be confused with an ileus pattern. Also, it's difficult to distinguish a partial versus an early small bowel obstruction. Indication for surgery are generalized peritonitis, localized peritonitis, visceral perforation, and irreducible hernia. Relative indications are a palpable mass, a virgin abdomen, or failure to improve with non-operative therapy. Non-operative trial is indicated in patients with incomplete bowel obstruction, previous surgeries, advanced malignancy, and when the diagnosis of small bowel obstruction is in doubt. One finding that requires prompt surgery is strangulation. This usually results in complete obstruction, vascular compromise, and can progress to infarction and perforation. Unfortunately, there are no pathognomonic signs or symptoms, so high index of suspicion is warranted. Besides history and physical examination, radiologic studies can help in making diagnosis. Abdominal x-rays can be very useful in distinguishing ileus from obstruction. Signs of obstruction on upright or left lateral decubitus film include dilated small bowel loops of 3 centimeters or greater, central valvulae conaventes, multiple air fluid levels as noted in this x-ray, air fluid levels in the same loop of small bowel of unequal heights, giving a slinky type appearance, string of pearl sign, and paucity of gas in the large bowel. Supine x-rays, there are dilated small bowel loops of more than 3 centimeters, small bowel dilated out of proportion to the colon, paucity of gas in the large bowel, and the stretch sign, which is seen in the far right, where there's small bowel partially filled with gas outlining the valvulae conaventes. CT scans can be very helpful. One advantage of CT scan over plain radiographs is that it can give you increased confidence of identifying the transition point, which is the site where the dilated bowel transitions to decompressed bowel. Also, CT scan provides an excellent evaluation of the bowel wall, its vessels, and adjacent mesentery, which permits the identification of coexistent ischemia and/or infarction. CT also provides an excellent evaluation for the presence of bowel perforation and the presence of extraluminal gas. CT findings suggestive of ischemia are listed here. Bowel wall thickening greater than 3 millimeters, mesenteric edema, fluid in the mesentery and or peritoneal cavity, occlusion of mesenteric vessels, engorged mesenteric vessels, whorl sign, which is where the bowel rotates around the mesentery, leading to whorls of the mesenteric vessels, as noted in the CT scan with the arrow. Closed loop obstruction of volvulus, pneumatosis, mesenteric venous gas, and portal venous gas. Closed loop obstruction occurs when a segment of bowel is shortened at or obstructed at 2 points along its course. This results in progressive accumulation of fluid and gas within the isolated loop, placing it at risk for ischemia and perforation. CT findings of a closed loop obstruction depend in part on the orientation of the loop relative to the plane of imaging. Some of the findings are marked extension of a segment of small bowel greater than 3 centimeters, radially distributed C or U-shaped small bowel loops seen at about 9 o'clock on this slide, double beak sign, which is tapering of the bowel loops at the point of obstruction seen around 7 o'clock on the slide, whorl sign of the tightly twisted mesentery seen at about 2 o'clock in this slide, 2 adjacent collapsed loops of bowel seen around 5 o'clock in this slide, and if strangulation is present, then there may be signs of bowel ischemia. Who needs surgery? How do we identify patients who will benefit most from early operation? The surgeon's gestalt may not be sufficiently accurate or reliable. In the last decade, an increased number of studies have focused on the utility of CT features in addition to clinical symptoms and signs to determine who will benefit from operative intervention in the management of adhesive small bowel obstruction. Zielinski and colleagues created a prediction model, including clinical and CT signs in a retrospective study. They then conducted a prospective study to validate their model. They found that 86% of patients who had all of these signs listed, vomiting, obstipation, small bowel feces sign, and mesenteric edema needed surgical exploration, and 29% of those had strangulation. Another recent study that was prospective observational of 3 US trauma centers identified 1 clinical symptom and 2 CT findings that were significant predictors for early operation in adhesive small bowel obstruction. These were no flatus, in addition to free fluid on CT scan and high grade obstruction on CT scan. They found that 56% of patients required an early operation. They also noted that the median days from admission to operation among 3 participating centers was 1.5 days, and that the median length of stay in patients successfully managed non-operatively was only 2 days. So in summary, the decision for surgical intervention is based on history, physical examination, laboratory tests, radiographic studies, and CT scan. These will determine whether a patient needs early surgery or non-operative management. Patients who are in the non-operative management group will need constant reevaluation to determine if they will need surgery. Next, we're going to discuss adhesive small bowel obstructions. There has been a lot of literature that has come out on this in the last 5 to 10 years. Adhesive small bowel obstruction are common, are the leading cause of small bowel obstruction. It is associated with significant length of stay and in-hospital mortality. It requires reoperation in 20 to 30% of cases, with the highest following colorectal surgery, oncologic, non-oncologic surgery, or pediatric surgery. 1 in 10 patients develop small bowel obstruction within 3 years after colectomy, and reoperations for adhesive small bowel obstruction occur in about 3.2% of patients following colectomy. Recurrence of adhesive small bowel obstruction, those treated non-operatively, is 12% within 1 year and 20% at 5 years. In those treated operatively, the recurrence of adhesive small bowel obstruction is lower at 8% at 1 year and 16% at 5 years. Management of adhesive small bowel obstruction is similar to other causes of small bowel obstruction. Non-operative management includes bowel rest, gastric decompression, rehydration, and monitoring for signs of peritonitis, ischemia, or perforation. CT scan is performed to rule out findings associated with strangulation and ischemia. The main difference with adhesive small bowel obstruction is the use of water-soluble contrast studies. This can be diagnostic and potentially therapeutic. Studies have shown lower rates of operative intervention and shorter length of stay with water-soluble contrast studies. Has treatment of adhesive small bowel obstruction changed? A review of the national inpatient sample from 2003 to 2013 of almost 2 million patients demonstrated a decrease in surgical interventions, decrease in days to operation, decrease in in-hospital mortality, and decrease in hospital length of stay, as well as an increased operation within 24 hours. They showed a difference in the paradigm in the management of small bowel obstruction from 2003 to 2013. This could partially be due to the use of water-soluble contrast, but the data was not available in this NIS database study. There are increasing number of institutions that use water-soluble contrast in a trial of non-operative management of adhesive small bowel obstruction as standard practice. This algorithm includes administration of water-soluble contrast via NG tube and then serial abdominal radiographs taken every 4 to 6 hours. The indication for surgical intervention is usually defined as a failure to pass contrast to the ascending colon within 8 to 24 hours. The benefits of this protocol are twofold. Serial radiographs follow the passage of contrast and can help diagnose whether the patient has a complete obstruction. Second potential benefit is a therapeutic one from the contrast high osmolarity that facilitates decrease in edema of the small bowel and help relieve the intraluminal pressure. This protocol helps to determine within 24 to 28 hours whether the patient with adhesive small bowel obstruction requires surgery. A recent multi-center study looked at the use of water-soluble contrast for adhesive small bowel obstruction, and of note, 11 of 14 or 79% of participating institutions had previously implemented the water-soluble contrast challenge for the management of adhesive small bowel obstruction. This study included 316 patients. Their findings were a significantly lower rate of operative exploration water-soluble contrast group, 21% versus 49% in the non-contrast group, significantly lesser rate of misstrangulation obstructions in the gastrographic cohort compared to the non-gastrographic cohort of 0.6% versus 7.7%. Additionally, in 2018, the Bologna guidelines were revised. This guidelines was written under the auspices of the World Society of Emergency Surgery by the Adhesive Small Bowel Obstruction Working Group. They performed systematic literature research prior to the update of the guidelines to identify relevant new papers on epidemiology, diagnosis, and treatment of adhesive small bowel obstruction. The literature was critically appraised according to the evidence-based guidelines were developed. Their recommendations were adhesion formation might be reduced by minimally invasive surgical techniques and the use of adhesion barriers such as Seprafilm. 2, CT is the diagnostic technique of choice when the adhesive etiology of obstruction is unsure or when contraindications for non-operative management might be present. 3, the principles of non-operative treatment are nothing by mouth, nasogastric or long tube decompression, and intravenous supplementation with fluids and electrolytes. And 4, when operative treatment is required, a laparoscopic approach may be beneficial for selected cases of simple adhesive small bowel obstruction. They proposed a diagnosis guideline for adhesive small bowel obstruction, and this is similar to protocols used for any type of small bowel obstruction. Adequate history, physical examination, laboratory studies, and to determine if patient has had previous surgeries. If there's suspicion for adhesive small bowel obstruction, patient then undergoes the supine and erect abdominal X-ray and proceeds to abdominal CT with IV contrast if there is some concern for small bowel obstruction. This will then determine if patient needs emergency surgery, if there's evidence of ischemia or strangulation, or proceed to non-operative treatment with water-soluble contrast study. They also mentioned abdominal ultrasound and abdominal MRI, which is of limited value. Their algorithm for treatment of adhesive small bowel obstruction is noted here. Surgical exploration is required in patients who have signs of strangulation or peritonitis, surgery within 6 weeks before adhesive small bowel obstruction, carcinomatosis, or irreducible hernia, no signs of resolution within 72 hours. Also, patients who have water-soluble contrast studies with no contrast in the colon by 24 to 36 hours proceed to operative management. Failure of non-operative treatment are listed here. Peritonitis or ischemia, persistent ileus greater than 72 hours, drainage greater than 500 milliliters on the 3rd day by nasogastric tube, pain lasting 4 days or more, CRP greater than 75, white blood cell greater than 10,000, and free intraperitoneal fluid greater than 500 milliliters on CT scan. Next, we're going to go over operative intervention, in particular, open versus laparoscopic approach. Laparotomy continues to be considered the standard surgical approach at most centers. The first laparoscopic adhesiolysis for adhesive small bowel obstruction was performed in 1972. Several retrospective papers have been published with favorable results of laparoscopic small bowel adhesiolysis. Implementation of laparoscopic surgery for adhesive small bowel obstruction has been slow, and there's concern for an increased risk of iatrogenic bowel injury. Unfortunately, evidence supporting laparoscopy over open surgery in reducing the risk for adhesive small bowel obstruction recurrence is not strong. Drawbacks related with the laparoscopic approach in adhesive small bowel obstruction are risk of intraoperative bowel injury, difficulty handling the bowel loops, difficulty obtaining a correct view of the cause of the obstruction. The one absolute contraindication is hemodynamic instability or cardiopulmonary impairment exacerbated by pneumoperitoneum. The absence of prospective randomized studies and the lack of consensus in the indications regarding the most appropriate approach have meant that laparoscopy remains the second option of surgical treatment of adhesive small bowel obstruction. Advantages of endoscopic or laparoscopic adhesiolysis from retrospective studies show earlier onset of oral intake, shorter hospital stay, less postoperative pain, and decreased mortality. Disadvantages are a high conversion rate of 26 to 58% and a higher morbidity in those requiring conversion. Several studies have been published on the use of laparoscopic management of small bowel obstruction, one of which is a review of the American College of Surgeons National Surgical Quality Improvement Program, or NSQIP, database from 2005 to 2009. This study evaluated the use of open laparotomy versus laparoscopy for adhesive small bowel obstruction. It was reported in 2014. There were 6,762 patients who underwent adhesiolysis. The study found laparoscopy had lower rates of complications, superficial infections, intraoperative transfusions, and shorter hospital stay. There was no significant difference in operative time, rate of operation at 30 days, or mortality. The authors concluded that laparoscopic treatment of small bowel obstruction was safe. It was associated with lower post-op morbidity and shorter hospital stay compared to open laparotomy. There are many retrospective studies in the literature on laparoscopic adhesiolysis for adhesive small bowel obstruction. A recent international multi-center parallel open label trial was reported in 2019. Patients with adhesive small bowel obstruction that did not resolve with conservative management were randomly assigned to laparoscopic versus open surgery. This included 5 academic university hospitals and 3 community hospitals in Italy and Finland. Only patients with high likelihood of single adhesive bands were included in the study. The findings were a significant decrease in hospital length of stay, a trend toward decreased complication, and no difference in mortality. In summary, this randomized prospective study was not as positive as the many retrospective studies in the literature. Finally, a recent meta-analysis of 14 studies were reported in 2020. This included 1 randomized controlled trial, 2 matched studies, and 11 unmatched studies. Results of the primary analysis looking at the prospective randomized trial and the matched studies showed no significant difference in core outcome parameters, including postoperative mortality, iatrogenic bowel perforation, length of postoperative stay, severe postoperative complications, and early admission. When they analyzed all of the data from all of the studies, including the 11 unmatched studies, they found that laparoscopic surgery was favored over open adhesiolysis in postoperative mortality, length of postoperative hospital stay, operative time, time to flatus, severe postoperative complications, and early unplanned reoperation. Their conclusions were that the systematic review indicated that laparoscopic surgery was safe and feasible. In conclusion, the standard workup for small bowel obstruction is history, physical examination, abdominal radiographs, and CT scans with IV contrast. This will determine who will need emergency or urgent surgery. Water-soluble contrast study is helpful in patients with adhesive small bowel obstruction to determine complete obstruction and may be therapeutic in decreasing edema in the small bowel. Laparoscopy for adhesive small bowel obstruction is limited to patients who have possible single or minimal adhesions, as the data is not conclusive for use in the general population of small bowel obstruction. I'd like to thank the Society for the honor of presenting today, and I'm open to questions. Aloha, enjoy the meeting.
I believe we have Dr. Tamanaja on Zoom.
I'm here.
Okay, hello.
Hi.
That would be me. That would not, there you are. Hello there. Oh, you are in Hawaii.
Yeah,
No.
the virtual Hawaii.
Yeah, so, we have one question.
I would, this is Annabelle Barber from Las Vegas, and it's amazing that I can ask a question with a mask on. I mean, I think we're surgeons, so we can all speak and communicate well with masks. It's amazing. But at any rate, the point is that I would ask you your opinion on how we can convince our emergency department colleagues to get contrast with CTs. Where I am, they often will have a CAT scan with a patient with small bowel obstruction, and we end up giving the patient, low dose radiation therapy by the time we get a real CAT scan with IV and PO contrast, and then we get a small bowel series, and so we really are giving a significant dose of radiation. I mean, we've had a real difficult time at convincing our ER colleagues to get contrast CAT scans. Do you have any ideas about that?
So I think that's an ongoing problem. We constantly are re-educating our emergency room doctors. They have gotten better, but it's more patients who get transferred from the outside come in with CT scans with no IV or oral contrast. So it's just a one-on-one basis to educate those outside doctors, but definitely in our facility, I just keep hammering our ER doctors that you need to give IV contrast. And it's just ongoing, both for general surgery and for trauma patients.
Right. I think often the RME, or the rapid medical exam, is done by MLPs who are trying to save everyone's kidneys or whatever. And they've got an obstruction, so we have to keep them in PO. So we can't possibly give them contrast. So
Yeah, I think it's an ongoing problem.
Yeah. Thank you.
I think along those lines, Dr. Tamanaja, is, when you do the gastrographin challenge, so that's a highly hypertonic solution. And in case they do have an obstruction, they potentially are at higher risk for aspiration at the time of surgery if they fail the gastrographin challenge. So is there any recommendations in regards to removal of the contrast agent before the operation, or what are the protocols there? So you give, I think it's 300 mils of gastrographin, you wait 24 to 36 hours. If it doesn't progress, then they're off to the operating room. Do they recommend, attempts at removal of the agent prior to, and what are the intubation techniques? Are those patients always required to have a rapid sequence intubation to prevent pulmonary issues?
So there's different protocols on how much fluid that's given. On the one randomized trial that I quoted from Zielinski, they used gastrographin 30 cc's mixed in 100 cc's. And what we do is we usually put an NG tube in, we give the contrast, and we get an x-ray just to make sure it's in the right place. And if the patient is symptomatic, we put their NG tube back to suction. Otherwise, we leave it not to suction, we clamp it and follow them. But if they have any symptoms at all, we'll put them back to suction. And definitely once we know it's not gone far enough, we'll put their NG tube back to suction. Obviously, we do aspiration precautions with their head a bit elevated, and etc. In the Zielinski trial, they said they had one person who aspirated but did not develop any serious pneumonitis. So they found no big complication from giving the intro contrast. Definitely patients who, when you put a NG tube in, have large amount of NG output, we don't give contrast right away. So if you put it in and you get 500 cc's out, we would leave it to suction for a few hours and recheck them, and maybe even wait till the next morning to make sure their NG output's low, get an x-ray, make sure their stomach's not real dilated, proximal small bowel's not real dilated, and then give the contrast.
Thank you. Another
Brad
question?
Thomas, acute care surgeon out of Charlotte, CMC. We've had a protocol for gastrographin for about 5 years. I'm curious if what you've come across and what your thoughts are on utilization of gastrographin challenge in the early postoperative period within 30 days of surgery.
So we have not used it. I know that some places are, and I'd want to see, have you guys used it a lot from early on?
I think out of just the familiarity with the trainees that the gastrographin gets ordered in that time period, and the utility really seems pretty variable. I've only seen one study on this, and it's about a 50%. Or it's no better or worse using it or not using it as far as determining if they're going to progress on or not. I think it just maybe gives you a little more information.
Okay.
One final question for me is that I just want to have a show of hands of how many people are operating laparoscopically on small bowel obstructions. Start out laparoscopic. Pretty good percentage here, Gail. So what are the contraindications? Multiple episodes of small bowel obstructions, multiple prior surgeries, or are there any? You should always start out laparoscopically before an open technique.
The data, as far as the prospective randomized trial, is not real convincing, but there's a lot of retrospective reviews. And the one absolute contraindication is that somebody's hemodynamically unstable, and giving them pneumoperitoneum will make them more hemodynamically unstable. That would be the one contraindication. There's multiple studies say that they would not do it if patients had more than 2 previous exploratory laparotomies. Otherwise, all the studies do say that it needs to be done in the hands of somebody with laparoscopic experience, because there is risk to bowel perforation and having injuries to the bowel just in handling the bowel. So the data, though, there's one prospective randomized trial, is not overly convincing that it's better than open laparotomy. But there is multiple retrospective studies that say we have a bunch of patients that we did this and it worked well. But there have been studies showing that when patients are converted to open, that the complication rate is much higher.
Excellent. Thank you. Wish he could be with us, but thank you for a wonderful talk.
Yeah, miss everybody there. Have a good time in Maui.
Our final speaker is Josh Mammon, and he comes to us from now Nebraska after spending years and years at University of Kansas Medical Center. And Josh just want to say a few words about him, about his involvement in the Committee of Cancer. He served as chair of the University of Kansas Surgical Oncology Committee, a state of Kansas CDC-funded Comprehensive Cancer Coalition, and an assistant director of the Midwest Cancer Alliance, a partnership of institutions through states of Kansas and Missouri that collaborated to ensure clinical trials and optimal cancer care available throughout that region. Josh is a counselor for the American Board of Surgery. He's currently the chair of the Complex Surgical Oncology Board, as well as chair of the Training and Education Committee. He gives exams to both general surgeons here and the Complex Surgical Oncology Boards, as well as internationally. He provides board education and board examination. So welcome, Josh. And he's going to talk on melanoma for the general surgeon.
Thank you, Roxy. Appreciate it, the introduction. Before I begin my talk, I want to acknowledge, first of all, that this talk was initially supposed to be given in 2020 at the annual meeting then by Jim Edney. And he called me sometime this spring because he was going to have a conflict with this meeting, and he asked me to give this talk. So it's particularly poignant for me to be able to give this talk today. So no relevant disclosures. So all of you know kind of the basics of the challenge that melanoma poses with more than 100,000 new cases of melanoma in the United States every year, more than 7,000 deaths from melanoma annually. And it's one of the malignancies with the greatest increase in the number of cancer cases every year. And an individual's risk, and of course this varies based on risk factors, is about almost 2% in the lifetime. Knowing all of that, I really want to, for the purposes of this talk, really concentrate on some of the areas of greatest controversy and maybe some of the areas where there's the most changes. And I'll divide this up into 4 sections, one really focusing on surgical margins, which you would think that that's a settled question, but really it's actually far from settled for melanoma. The management of lymph nodes, which as you know, has evolved in many malignancies, including breast cancer, but also melanoma. Neoadjuvant therapy, which is an area of really substantial change in the treatment of melanoma. And then of course, in-transit disease, which is something we've been struggling with in the melanoma world for some time. So we'll start off talking about surgical margins first. So it's a very interesting topic because again, it would seem that surgical margins are a settled question. And this is actually taken from a trial which I'm helping to organize for participation in the United States. And in the United States, our typical strategy is for thin melanomas, less than 1 millimeter to do a 1 centimeter margin. For thicker melanomas, greater than 2 millimeters to do a 2 centimeter margin. And then the intermediate thickness melanomas is where we think there's controversy between 1 and 2 centimeter margins. Well, what's particularly interesting is in the rest of the world, they don't do exactly what we do. There's actually tremendous variation throughout the world, as you can see, and what margins individuals take. And in some European countries, in fact, 1 centimeter margins are much more common for even thicker melanomas. So it really begs the question, do we really need to do those huge margins that we do currently? And this is the trial that I was alluding to, which will be from SWOG 2015, but this is actually a trial that's largely out of Australia and New Zealand, looking at melanomas that are T2B. So this is essentially melanomas that are greater than 1 millimeter, in this case ulcerated, and looking at whether or not we really need to do a 2 centimeter margin for those individuals. It's a large trial, 3,000 individuals need to accrue to this trial. And the treatment arms are fairly straightforward, 1 centimeter versus 2 centimeter margins. Now, why does this matter? 1 centimeter versus 2 centimeters doesn't seem like that big of a deal, but for those of you who do some melanoma surgery, realize that the difference between a 2 centimeter margin versus a 1 centimeter margin is pretty significant, especially in certain parts of the body, head and neck, for example, hands, et cetera. But even on truncal regions or extremities, it's a difference between a 15 centimeter incision and a 7 centimeter incision. So the Melmar trial actually had an earlier version to it. This is a pilot study of Melmar, which was published in 2018. They looked at how often they needed to have a plastics reconstruction for a 2 centimeter margin versus a 1 centimeter margin. You can see here that needing a plastic reconstruction, regardless of the area of the body, was significantly different with a 2 centimeter margin versus a 1 centimeter margin. This seems intuitive, of course, but it really goes to bear that there's a significant cosmetic defects as well as functional defects that can result from having a 2 centimeter margin versus a 1 centimeter margin. One of the questions that I asked early on as we were contemplating this trial is, can we accrue to individuals in the United States? We, of course, have shared decision-making with our patients, particularly with intermediate thickness melanomas, as to whether or not they would have a 1 centimeter versus a 2 centimeter margin. And I did a kind of a small pilot version of this trial at my previous institution. And I looked at individuals who were in that intermediate range, essentially T2 melanomas. I excluded head and neck, hands, and feet, because I thought that in those situations, I wanted to make the decision, frankly. And also when they had a positive deep margin where I thought it was a little unfair to make the decision in that situation. So there were 146 patients that I saw during that 9-month time period. 41 of them had a T2 melanoma. And I excluded some because of the location of the body. So out of the 29 eligible patients, only 9 volunteered to participate. The rest of the individuals actually wanted to choose themselves. So essentially a third of the individuals volunteered to participate in this pilot study. So that means of those 3,000 individuals that we would need to have as subjects to that trial, essentially you have to ask 9,000 individuals on whether or not they'd be willing to participate in the trial. So it really shows the substantial effort that will be needed to have this trial to be able to accrue the number of patients that are needed. So again, more to be determined or more to come on that trial. But again, it really goes to that perhaps myth that the margins of melanoma are already a settled question. We may be doing smaller margins in the future. The next is with regards to management of lymph nodes. I think most of us are familiar with the sentinel lymph node biopsy, where you use a dual tracer technique, typically for melanoma, radionucleotide, as well as with a vital blue dye, and identify those lymph nodes. I think this is a pretty settled question, at least for now, on who should get a sentinel lymph node biopsy. It's 0.8 millimeters or thicker, which is a T1B melanoma or thicker. But there is some controversy with regards to thinner melanomas, particularly in younger individuals. And the reason for that is, while in the United States there are about 60,000 thin melanomas annually, approximately 30% of melanoma deaths happen in T1 melanomas and thinner melanomas. So as you would think that the thicker melanomas have higher risk of death due to the sheer number of thin melanomas, 30% of melanoma deaths are from individual thin melanomas. And at just under 4% of individuals with a 0.5 to 1 millimeter had a positive lymph node. But there are risk factors. Younger age and a mitotic rate appears to be risk factors, and particularly younger age. So we do have a little bit of help to be able to predict the likelihood of having a positive sentinel lymph node. And I would suggest that this nomogram is a really helpful one as you're helping patients to decide whether or not they should have a sentinel lymph node biopsy. This is from Memorial Sloan Kettering. I can never remember the website. I just put in nomogram, sentinel lymph node biopsy, Memorial Sloan Kettering. And it has variety of factors. And as you can see here on the top factor there is age, which is incredibly important. And then it spits out this very clear result which helps in your discussion with your patients, which is the likelihood of them having a positive sentinel lymph node. Another important factor is where are these sentinel lymph nodes? And while we think of the common sites, cervical, axillary, and inguinal, there are other sites to also consider. And these non-typical sites often can have sentinel lymph nodes as well. And then the reality, of course, is you won't find these sentinel lymph nodes unless you look. And these sites that you should also look for are the popliteal region, epitrochlear, as well as external iliac region. And what I mean by that you should look, you should, in addition to checking the typical sites, the cervical, axillary, inguinal sites with your gamma probe, also check those epitrochlear regions, the popliteal regions, the external iliac regions, because you'll be surprised at how often do you identify a sentinel lymph node. There also goes to the importance of lymphocytography in considering those alternate basins. And in fact, it substantially helps in certain regions, particularly head and neck and truncal regions, at finding additional sentinel lymph nodes that you would have otherwise missed. So particularly when you have a head and neck melanoma or a truncal melanoma, it's incredibly important to do lymphocytography to aid in your sentinel lymph node biopsies. And a final point with regards to sentinel lymph nodes, frozen section is generally contraindicated. I would strongly recommend against doing it. You have to really wait for final pathology. Now to go kind of a related topic with regards to sentinel lymph node biopsy is the question of when to do a lymphadenectomy. And the traditional indication had been a positive sentinel lymph node or when you had bulky disease. But this trial really changed things, which was MSLT2. And this trial is now a little bit older, and many of you are now familiar with this trial. But I think it's important to go over MSLT2 because I think it was a significant change from our previous practice. Again, a very simple surgical trial. It's in individuals who had a positive sentinel lymph node. They are randomized to either have a completion dissection or to active surveillance. And I would say it's not just completion dissection versus nothing. It's completion dissection versus active surveillance. And the active surveillance was a ultrasound every 3 to 4 months of that nodal basin, looking for a nodal recurrence and a dissection if a recurrence was detected. And what they found is that there was no difference in melanoma-specific survival. You can see these two curves of observation versus dissection completely overlap. And there was no difference in distant disease-free survival. And really ask you to concentrate on the red and blue lines. The lines above we're looking at for a PCR-detected sentinel lymph node disease and not really relevant to this discussion. But you can see there's no difference in distant disease-free survival as well in dissection versus active surveillance. However, there was a difference in disease-free survival, and you can see that the curves do diverge with the follow-up of 4 or 5 years between the dissection arm versus the active surveillance arm. And with regards to nodal recurrence, obviously there's a substantial difference if you did a lymphadenectomy versus if you did not do a lymphadenectomy up front. So I don't think it's completely transparent on exactly how to apply this. And I think this also goes to shared decision-making with your patients. First of all, there's limited follow-up, and the most recent updates on this trial, it only was 3.5 years of follow-up. It was a very selected patient population. The average size of the lymph node metastasis in the sentinel lymph node was 0.6 millimeters, which may be a lot smaller than many of the patients that you're seeing in terms of lymph node metastasis in the sentinel lymph node. There was intensive active surveillance at select centers that were very used to doing surveillance with ultrasonography. And there was limited information about adjuvant therapy. This was a pre-adjuvant therapy. So these patients were accrued prior to the effective systemic therapies being available. And so we don't really know exactly how adjuvant therapy plays into this. And again, another important point, and since many of you may do both breast cancer and melanoma surgery, this is not breast cancer. And I think there are some key differences between the ACOSAGA Z11 trial, which I had very different results and has a very different interpretation. First of all, unlike ACOG Z11, there was no standard adjuvant therapy. As you know, in ACOG Z11, all those patients received adjuvant radiation therapy as well. This is only 3-year data, follow-up data versus the Z11 trial, which had 10-year data now. There was a difference in disease-free survival in the MSLT2 trial, while in the ACOG trial, there was no difference in disease-free survival. And we do know that MSLT1, the precursor to MSLT2, suggested that finding disease early did have a difference in terms of survival. And I think, so really in terms of applying this trial, I think you have to really think of this as a difference between apples and oranges. I would not apply this in the same way that you apply Z11, which I feel can apply fairly liberally and confidently. This requires a little bit more nuance as well as discussion with your patients. Now moving on to neoadjuvant therapy. So the major neoadjuvant therapies that we've been using more recently is really immunotherapy, PD-1 inhibition or CTLA-4 inhibition. I should put pembrolizumab in addition to Nivo there. And then BRAF/MEK inhibition and Imlygic, which is often known as TVAC. But we're really focused on immunotherapy, nivolumab and ipilimumab, which has been used in some of the larger trials. This is a trial from Dr. Maria from MD Anderson, one of, I think, the early well-done neoadjuvant trials with melanoma. Again, a really simple design here. There were 2 arms in terms of neoadjuvant treatment. One was either with nivolumab as a single agent. The second arm was nivolumab and ipilimumab, so dual inhibition therapy. They treated the patients with several doses, surgical resection, followed by additional adjuvant treatment. And I really want to kind of point out the differences here. And really what I'm going to really highlight is this, where I highlighted in this circle, which is that 2 of these patients in the nivolumab arm who are previously resectable progressed to the point at which they were no longer resectable because of neoadjuvant therapy. So it's certainly something we don't want to see when you do a neoadjuvant approach. So we learned a lot from this trial. And one of this is neoadjuvant therapy doesn't always work. And sometimes when it doesn't work, you can make resectable patients unresectable. So it was really a cautionary trial, and this trial was actually closed early. But there were some pretty dramatic responses. This is, you can see a lymph node here prior to neoadjuvant therapy, and you can see after neoadjuvant therapy that it shrank, and there was actually a complete pathologic response in this lymph node in this patient in this trial. So we do sometimes have some tremendous pathologic responses in neoadjuvant therapy, and really great progression-free survival and overall survival. And the blue bar here is with the Ipi-Nivo arm for those patients that went on to resection. So they had a tremendous benefit from a neoadjuvant approach. So what I would say with regards to neoadjuvant therapy, it's currently not standard of care. There is some concern about durability of response. For example, if you give more than 3 cycles, 4 cycles, will they then start to progress? And that was a concern of those patients that progressed from being resectable to unresectable. And then losing that window of opportunity because of that. So in terms of takeaways, in terms of consideration, if you're considering a neoadjuvant approach, I think you ideally should do this as part of a clinical trial rather than doing it as a standard part of treatment. And one of the clinical trials that's available right now is SWOG 1801, which was with neoadjuvant pembrolizumab versus adjuvant only pembrolizumab, and a great trial. It's accruing quite well. It's pretty close to being closed, actually. But referring your patients to that type of trial, I think, would be something to consider. Also, limiting the amount of neoadjuvant therapy you get, maybe 2 or 3 cycles, really no more than really 6 to 8 weeks, because more than that risks the fact that you might lose that window of opportunity. And then, of course, all these patients should go on, if you're going to take that approach, to then get a full year of therapy, including in the adjuvant setting. The final area that I'm going to touch on is regional chemotherapy. This is the concept of delivering for in-transit disease high-dose chemotherapy to an extremity at a higher dose than you can deliver to the systemic circulation. The indications for this is multiple in-transit lesions, no evidence of distant metastatic disease, and it's critically important that the lesions be distal enough that you can actually do a perfusion or an infusion and be able to do the entirety of that extremity where the disease might be. There are essentially 2 basic flavors of this. There's a perfusion or an infusion. I think many of you may be familiar with these. And perfusion is essentially putting the leg or arm on bypass. You isolate out the vessels, control all the collaterals. If there is bulky disease or a lymph node disease, you do a formal lymphadenectomy, and then you cannulate the vessels. This is what the bypass circuit looks like. Essentially, it's using the same bypass machine that you use for a cardiopulmonary bypass. You have an oxygenator, a heat exchanger, and the cannulas going into the vessels. Once the circuit has been established, you monitor for a leak to make sure that the chemotherapy is not going to go into the systemic circulation. Warming blankets, temperature probes to ensure that you're adequately heating the extremity. And you circulate the chemotherapy typically for an hour in most protocols, anywhere from a rate of 400 to 600 ml. Sometimes you get a little higher. You oxygenate the blood throughout the entirety of the perfusion, exsanguinate the extremity at the end of the perfusion, then reestablish continuity. The blood itself is washed out through a cell saver circuit and the reinfused into the patient. The infusion is kind of I often refer to this as the difference between a heart bypass and a heart cath, a little bit oversimplistic, admittedly, but it's a percutaneous access to these vessels. Use a pneumatic tourniquet, and you manually circulate the chemotherapeutic agent for 30 minutes at a time. This is an example or a cartoon of what a infusion would look like, with catheters typically inserted on the contralateral extremity and run over to the other limb to do the infusion. This is just some pictures to kind of give you a little bit of a visual idea of what it looks like. We have a tourniquet high up, which is held up, and then you have the catheters going into, in this case, into a groin. This is just a little bit of video that kind of shows what the setup looks like. We have that green warming blanket, you have the catheters that are going into the groin, and then with tubing going all the way to this bypass circuit where it's oxygenating and heating the blood and the chemotherapeutic agent in that blood. This is just another view. This is during the washout. You can see the clear infusate washing out the extremity, but just kind of showing a little bit about what the setup looks like. And then finally, after the perfusion has been completed, we wash out the blood. You just use a typical cell saver or circuit with a filter that can remove the chemotherapeutic agent. And then we're able to retransfuse that blood back to the patient so we can avoid having to do a blood transfusion. The typical agent that's used is melphalan, which is really not very good systemically for anything other than wiping out the bone marrow, used sometimes for bone marrow transplantation, but it works really well for perfusions and infusions. Some had some really favorable properties, a really low half-life, low soft tissue toxicity, and a linear dose response curve, and it is synergistic with heat. And during this perfusion infusion, it's heated. Dosage is based upon the volume of the extremity. One of my aspirational goals is to have a dunk tank like this, so I don't have to manually measure the extremity, which is what I do right now. And you base the volume of chemotherapeutic agent that you give based upon the volume of the extremity. I have to do some fancy math. Well, I really use an Excel file, but it works. Outcomes are tremendous, and I would say that still this is one of these techniques that's incredibly old, but still works really well. Complete response rates are almost 60%, overall response rate of almost 90%. So there's really nothing in melanoma that works quite as well for intravenous disease even now. Infusions almost work as well, but you can see that the complete response rate is not quite as good. So I still prefer perfusions to infusions because I'll take a 15% increased response rate anytime. And the toxicities are relatively low. The risk of an amputation, which is what is kind of that feared complication, is almost allegorical nowadays. It really almost never happens. It's a very safe technique. Another option is using Logic, which is that herpes virus that's attached to GM-CSF, which is injected. Its response rate is something like 30 to 40%. It has an abscopal effect. So it's not just the lesions that are injected that benefit, but some of those other lesions as well, and it appears to have a systemic effect as well. So in summary, I would say margins remain important, more to come based upon future trials. We may be able to do smaller margins in the future. Once Melmar is open, which should be later in this year, I hope that many of your centers will choose to participate. There's more and more discussion about avoiding lymphadenectomy, but it has to be done in the correct patients for the correct indications. So don't just apply the ACOSOG Z11 principles, but there are specific principles for MSLT2 to consider for shared decision-making. We're at the early stages of understanding exactly how neoadjuvant therapy works. I'm a big fan of the neoadjuvant approach, but it should be done cautiously and for a limited time frame at this point, and ideally in a clinical trial. And I think that regional chemotherapy continues to have a role in select patients with intransigent disease and needs to continue to be considered. And with that, happy to answer questions.
Josh, I know you've set up a regional center for surgical oncology in Missouri and in Kansas. Is that the type of center that should be running these clinical trials? Because I don't, I don't see this disease. I'm a acute care surgeon, but how many in-transit patients are there out there, and how many centers do we need to be doing this isolated limb perfusion?
Right. And I think you're pointing out a really excellent point, which is really you want to not just do one or two of these procedures. You really, volume matters for much of oncologic surgery. And I would say that's especially for procedures that require a tremendous team effort. When I do these procedures, I do it with one vascular surgeon who always works with me, and a group of perfusionists that always work with me, and a nuclear medicine group that knows exactly what I'm doing. So I do agree that it probably is something that, is done at a few centers. That being said, now that I move locations, I'm seeing patients from Kansas, of course. And so I do about one of these procedures a month. It's not a huge volume, but divided over many centers, it would be, we would be doing maybe just one a year. But the fact that there's referrals coming from multiple parts of our state as well as from other states allows us to have the volume to be able to do this in a kind of a reproducible fashion where we can try to maintain the quality.
And how long is it taking you to set up this in the new center?
Right. Yeah. So we had a lot of meetings, and that is an important point. I think that prior to doing a single one of these procedures at my new institution, I think we met for a good 10 hours of separate meetings to make sure that all the players were involved. And the first couple of these, we certainly met immediately before the procedure and did a debrief afterwards. Now that we've become more familiar, I think we've done 6 or 7 of these at this point. Everyone's become more comfortable, and I think they'll continue to improve over time. But yes, early on, it certainly is a tremendous activation energy to get things up and running again. And I would say, and this really shows the collaborative nature of all of our practices. As I set up this program in Omaha, the perfusionists in Omaha spoke to the perfusionists down in Kansas City, and everyone was incredibly collegial. And it really goes to show how tremendously collegial we are in medicine when we really care about the patient and put them first.
Well, thank you. I want to thank all the presenters today. Excellent talks. And I want to thank the program committee for arranging this surgical practicum session. So thank you very much, everybody.